Hello, awesome staff of the Northwest Kidney Center, particularly at the flagship unit in Kent, with a shout out to our little sister unit in Panther Lake. Today we're going to talk about common viral respiratory infections. So we are clearly entering flu season, and it's good to realize that these infections are already amongst us and can cause significant morbidity among our patients. We need to recognize the symptoms and know how to limit their spread. This talk has three objectives. First, we'll review influenza, COVID-19, and RSV infections, three of the most common causes of upper respiratory tract infections in our patients these days. I want you to appreciate the potential complications of these infections, particularly among dialysis patients, and have a sense of how to prevent these infections. Okay, let's launch into our first topic, which is influenza. Influenza is commonly known as the flu, and it's an infectious disease caused by a family of influenza viruses. The term influenza comes from the Italian word influenza, which comes from the Latin influentia, which means visitation or influence. And it's an appropriate term because influenza has influenced human civilization for thousands of years. There are many potential complications, including severe respiratory distress syndrome. It can affect your brain and cause meningitis and encephalitis, and it can exacerbate pre-existing health problems such as asthma or cardiovascular disease. Influenza viruses comprise four species: influenza A, B, C, and D. These are members of the Orthomyxoviridae family. They are negative-sense single-stranded RNA viruses. The RNA is segmented, and influenza A is responsible for most cases of severe illness, as well as seasonal epidemics and occasional pandemics. Influenza B mainly infects humans, but it can infect animals. The largest reservoir of influenza is found among birds and mammals, both domestic and wild. So it's not uncommon for influenza to spread from an animal with whom a human has had contact to a human and then cause either an epidemic or a pandemic. Influenza A viruses are divided into subtypes based on two proteins found on the surface of the virus, either hemagglutinin, which is abbreviated H, or neuraminidase, which is abbreviated N. And there are a whole bunch of different subtypes. There are 18 different hemagglutinin subtypes and 11 different neuraminidase subtypes. And that is where our nomenclature comes from when you hear of certain viruses circulating, like H1N1 viruses. Now, there are actually more than 130 different influenza A subtype combinations that have been identified in nature. Most, again, occur in birds and animals, but there are potentially many more influenza A subtype combinations because the virus has the ability to engage in something called reassortment. Reassortment is a process by which influenza viruses swap gene segments, and it can occur most often when two influenza viruses infect a host at the same time. They invade the same cell and they begin the process of replication, and then they swap genetic information in that encounter. Certain subtypes of influenza A viruses routinely circulate in people, and these are the H1N1, H3N2. Again, you may have heard of these in the news, for example, when we have an outbreak or an epidemic. Now, it's the variability of the surface protein expression that requires annual adjustment of the influenza vaccine. So because of the ability of influenza to essentially very quickly change its genetic material through the process of reassortment, we have to constantly vary the influenza vaccine. In temperate regions of the world, say where we live, the number of influenza cases peaks during the winter, whereas tropics influenza can occur year-round. In a typical year, 5 to 15% of the patients contracts influenza. There are 3 to 5 million cases, severe cases annually, and up to 650,000 respiratory-related deaths globally each year that are attributed to influenza. Now, these deaths most often occur in high-risk groups, particularly the very young or the very old, or people with chronic health conditions such as dialysis patients. And infections are characterized by seasonal epidemics and sporadic pandemics. These terms don't need a lot of introduction since we've just lived through a pandemic, but an epidemic is a widespread infection and a pandemic is a global spread of that infection. And since the late 1800s, large outbreaks of novel influenza strains have spread globally, and these cause pandemics typically every 10 to 50 years. And there have been 5 flu pandemics that have occurred since 1900. The Spanish flu in 1918, the Asian flu in 1957, Hong Kong flu in 1968, the Russian flu in 1977, and the swine flu pandemic in 2009. The 1918-1990 flu pandemic killed more people in absolute numbers than any other disease outbreak in history. Contemporary estimates put the death toll at around 21 million, but epidemiologists and scientists have revised that figure upwards several times. A 2002 epidemiologic study estimates that the actual number of deaths was really between 50 and 100 million. And the world's population at that time was 1.8 billion, so you're looking at about 5% of the world's population died from influenza in this pandemic. It's a lot less than with the COVID pandemic, depending on the estimates that people have made. COVID probably killed upwards of 4 to 5 million people. In humans, influenza viruses are primarily transmitted through respiratory droplets produced from coughing and sneezing. Transmission through aerosols and immediate objects and surfaces contaminated by the virus can also occur. The influenza virus can live on a hard surface for 1 to 2 days and has been shown to live up to 17 days on banknotes or paper money. The typical presentation of influenza after 1 to 2 day incubation period involves chills, fever, sore throat, muscle pains, headache, coughing, weakness, fatigue, general discomfort, nausea, and vomiting. It's also known as the hit by a truck disease because the onset of these symptoms is often very sudden. Can lead to pneumonia, particularly a superimposed bacterial pneumonia. The standard duration of influenza symptoms is 2 to 8 days. So how do we prevent influenza? Well, most of you already know the most important way is by not touching your eyes, nose, and mouth. We inoculate ourselves in most cases with all of these respiratory infections. Of course, you have to wash your hands a lot, which we do in the dialysis units. If you sneeze or cough, try to cover your nose, not sneeze on your neighbor. Avoid close contact with sick people. Stay at home if you're sick. And we're very good in the dialysis unit of sterilizing surfaces with bleach. Masks are of questionable benefit in influenza. Research thus far has not shown a significant reduction in seasonal influenza with mask usage. Annual vaccination is another very important way to prevent influenza and its complications, especially in high-risk groups. Vaccines against flu can be either trivalent, which includes material from 2 influenza A viruses and 1 influenza B strain, or quadrivalent, which carries material from 2 influenza A viruses and 2 influenza B virus strains. There's no risk of transmitting disease with the injectable vaccine and has very low reactivity, is very well tolerated. It is a killed vaccine, so it is safe for transplant patients. On the other hand, there is a live intranasal vaccine which can cause mild clinical symptoms such as runny nose. Contraindications to receiving the vaccine include severe egg allergy, or if you're just feeling sick in general, we don't want to give vaccines to people who are already ill. Treatment of influenza in cases of mild or moderate illness is generally supportive. Includes antipyretic medications such as Tylenol, ibuprofen, lots of fluids, chicken noodle soup, cough drops, rest at home. If a secondary bacterial infection occurs and treatment with antibiotics may be necessary. And of course, we have antiviral drugs primarily used for people with severe illness or those with compromised immune systems. And that would include dialysis patients. Antiviral agents are most effective when started within the first 48 hours after the onset of symptoms. And the main antiviral agents available to us include Tamiflu, which is also called oseltamivir, and amantadine. The latter is just helpful for influenza A. Tamiflu is effective against both influenza A and influenza B. The prognosis with most influenza infections is good, particularly among those who are healthy. People typically have symptoms for about a week, sometimes less, had to skip school or skip work, but thereafter recover. Sometimes you can have fatigue and just feeling lousy for several weeks after a viral infection such as this, but recovery is usually complete. On the other hand, those who are elderly or have compromised immune systems or multiple medical problems such as dialysis patients, these are the patients who are more susceptible to complications. And the main complication that we worry about is pneumonia. It can be a primary viral pneumonia, or you can have a secondary bacterial pneumonia. Couple of notable myths about vaccine. First, I could get the flu from vaccination. So the injectable vaccine involves virus particles. They are killed. They are not infectious. There is zero risk of transmitting disease. There's very low reactivity. Myth number two, if I have an organ transplant, flu vaccination could be harmful. That's not true as well, again, if you're using the injectable kind, which is just virus proteins. Now, as an aside, as I mentioned earlier, there is the intranasal live attenuated vaccine that is not appropriate for people who are relatively immunosuppressed, such as dialysis patients or clearly transplant patients, so they would not receive a live vaccine. Contraindications to receiving the influenza vaccine include a severe allergy to eggs, because eggs are used to make the vaccine in most cases, latex allergy, current moderate or severe illness, and finally, history of a neurologic condition called Guillain-Barré syndrome. It's a condition of ascending paralysis that has sort of dubious connection to the influenza vaccine. In summary, influenza can and has had a devastating worldwide impact. Symptoms often begin suddenly. It's the hit by a truck disease, typically featuring fever, cough, muscle aches, and fatigue. We can prevent the flu with proper hygiene and vaccination. And vaccination helps prevent infection as well as attenuate or decrease its severity. Let's begin the second part of our talk. This is an update on COVID-19. COVID-19 is caused by a coronavirus. It's a family of single-stranded RNA viruses whose name corona means crown or halo. So the name comes from its shape. It resembles a crown or solar corona when imaged under the electron microscope. It's a family of viruses discovered in the 1960s. It's a cause of disease in mammals and birds, and the most common presentation in humans is the common cold. Coronaviruses are most often spread through close contact, in particular through respiratory droplets and sneezes within close range, but they can also contaminate surfaces such as door handles and railings. They can live on surfaces such as glass up to 5 days. And as I said earlier, most of the time we inoculate ourselves with these infections. We touch a surface and we rub our eyes or touch our mouth. A high percentage of people who contract a coronavirus infection will have no symptoms at all. Estimates in literature vary, but appears to occur in up to 40% of cases. People have the virus and yet have no symptoms. Among those who have symptoms, typically they tend to be mild and include dry cough, muscle aches, headache. Less common symptoms include sneezing, runny nose, sore throat, nausea, diarrhea, abnormalities in smell or taste, as well as a skin rash. The most frequent serious manifestation of the infection is pneumonia, which typically presents with fever, cough, shortness of breath, and it can progress to severe respiratory failure, so-called respiratory distress syndrome. The spectrum of symptomatic infection ranges from mild to critical. Most infections are not severe. A report from the Chinese Center of Disease Control and Prevention during the first months of the COVID pandemic looked at 44,000 confirmed infections and reported the following. Mild disease was present in 81%, severe disease was found in 14%, and this included hypoxia, pneumonia. Critical disease with respiratory multi-organ failure was found in 5%, and the overall fatality rate was 2.3%. But the virus has mutated several times over the last 3 years and tends to cause less severe disease now. So the current fatality rate is estimated to be well less than 1%. That said, since many of the COVID infections are asymptomatic and many mild infections do not get diagnosed, the actual fatality rate is probably even lower than what's been reported, maybe less than 0.1%. Factors that modify mortality rate include age, so mortality is higher among the young and the elderly. It's worse in men compared with women. It is disproportionately high among African Americans, Hispanics, and Asians compared to Caucasians, at least in the United States. Lower socioeconomic groups fare worse than higher, probably relating to access to care. And the fatality rate is highest among those with comorbidities, so those who are immunosuppressed, and that again includes patients who are on dialysis. In analysis of 300,000 confirmed COVID cases in the US, mortality rate was 12 times higher among patients with comorbidities compared to those with none. Infection with COVID generally develops within 14 days of exposure. Most cases occur 4 to 5 days after exposure. It's a little bit shorter with the Omicron variant at 3 days. Potential complications associated with COVID infection include pneumonia, severe respiratory failure, the acute respiratory distress syndrome. People can develop blood clots more easily when they have COVID infection, cardiac injury. You can even develop acute kidney injury when you have COVID infection. Vaccination against COVID reduces the risk of severe illness and also is associated with decreased mortality. Adults over the age of 80 years, however, and those who are immunocompromised remain at increased risk for severe disease even if they've been vaccinated. Most of you are familiar with the new technology involved in creating the COVID vaccine. It's a messenger RNA vaccine. Basically, it contains mRNA, so the genetic code for the spike protein on the COVID-19 virus surface. The mRNA is directly injected into humans. Your own cells end up becoming a factory for your own vaccine. So it gets injected intramuscularly, so the first cells start to produce the protein or muscle cells, but then the mRNA gets delivered to multiple types of cells in the body. This sort of vaccine is faster to make, and you can basically come up with a formula within just a matter of weeks. All of you are probably familiar with the side effects associated with mRNA vaccination. These include injection site pain and redness. You can have systemic symptoms such as fatigue, chills, joint pain, fever, muscle pain. Rarely you can get severe symptoms including difficulty breathing or swelling of the face and throat, as well as a rash. 81% of the US population received the COVID vaccine with an effectiveness of 76% in preventing severe infection and hospitalization requiring mechanical ventilation. All right, the third and final virus we'll talk about is respiratory syncytial virus, or RSV. RSV is a very contagious, common virus. It causes infection of the respiratory tract. It can cause infections of all groups. So it's a notable pathogen in all groups, not just infants and children. Infections are typically most common during the winter months, as with influenza. Can cause outbreaks both in community and hospital settings. Each year, between 60,000 and 160,000 older adults in the U.S. are hospitalized for RSV infection, and between 6,000 and 10,000 of them die from it. RSV is a negative sense single-stranded RNA virus. Following initial infection, usually through the eyes and nose, again, most often self-inoculated, the virus infects the cells that line the airway, the epithelial cells, and that causes a lot of inflammation, cell damage, and potentially airway obstruction, which compromises people's ability to breathe. There's a wide range of clinical presentations. As with COVID and influenza, you can be asymptomatic. Most commonly, people have runny nose, sore throat, fever, and just feeling lousy, or so-called malaise. Unlike the other viruses, it's more likely to cause wheezing in adults. And about 25% of infected adults will develop significant lower respiratory tract infections such as bronchitis or tracheobronchitis. This is a highly contagious virus, which has been shown in many instances to cause outbreaks in community settings and hospitals. For each person infected with RSV, it's estimated that 5 to 25 uninfected people will get infected. It can spread from an infected person through coughing or sneezing, releasing contaminant drops in the air, and of course, we can self-inoculate ourselves when we touch our eyes and our mouth and our nose. The virus can live about 25 minutes on contaminated skin, so you shake someone's hand, but several hours on other surfaces such as countertops and doorknobs. Incubation period is 2 to 8 days. Once infected, people are typically contagious for 3 to 8 days, although in very young hosts, such as children or those with weakened immune systems, sometimes the virus can continue to proliferate for up to 4 weeks or even longer. As with COVID and influenza, the main ways of preventing infection include frequent hand washing, avoiding close contact with infected individuals, not touching your eyes, your mouth, your nose, and finally, vaccination. This is an exciting time because for the first time in medical history, in May of 2023, the FDA approved 2 RSV vaccines indicated for adults 60 years and above. They are recombinant subunit vaccines, so they're not mRNA vaccines. They contain virus particles, which stimulates the body to make antibodies against those virus proteins. Single-dose vaccines, so you don't need a series. They're shown to protect against lower respiratory tract disease caused by RSV in adults ages 60 and older with greater than 80% efficacy. The administration is associated with mild side effects similar to the flu and COVID-19 vaccines. Okay, let's go ahead and summarize what we've learned today. First, this is flu season, but broadly speaking, it's really upper respiratory tract infection season. Many viruses circulate in the community and can cause URI symptoms beyond just influenza, COVID-19, and RSV, but I focus on these 3 today because they're so common. All 3 of these are RNA viruses that are transmitted through coughing, sneezing, and self-inoculation by touching your mouth and eyes. Most infections are mild, although all 3 can produce severe clinical problems, including pneumonia. The fatality rate with all 3 is low, but it is higher in those with comorbidities, such as dialysis patients. Vaccines are now available for all 3 of these viral infections, RSV for those who are 60 years and above, and we should encourage our patients to receive them. Okay, I hope you are paying attention because we have a very hard quiz this time. Question number 1. mRNA vaccines are available for which of the following infections? Influenza, COVID-19, RSV, or HIV? Turns out the only mRNA vaccine we have right now is for COVID-19. For influenza and RSV, these are recombinant vaccines, and there is no vaccine for HIV. Question number 2, which virus caused the worst pandemic in human history with respect to loss of lives? That's right. The influenza pandemic of 1918 to 1919, it dwarfed all other infectious pandemics in human history. Question number 3. Which virus can survive the longest on an inert surface? So COVID-19 can last up to 5 days on glass. Influenza typically is 1 to 2 days on an inert surface, but has been documented up to 17 days on money or banknotes. And RSV is the shortest duration of survival of several hours. Next question. Vaccination was made available for this virus for the first time in history in 2023. That's right, RSV vaccine. It's a big breakthrough and hopefully will reduce infections among immunosuppressed and relatively immunocompromised patients such as dialysis patients. Final question, true or false, surgical masks have been shown to slow the spread of influenza? The answer is actually false, and I'm not saying that we shouldn't wear masks. I'm just saying that the data thus far have not shown that we can slow the spread of infection of influenza by wearing surgical masks. This concludes the October 2023 in-service on upper respiratory tract infections, what a dialysis provider needs to know. Remember, wash your hands a lot, don't touch your mouth and nose, and have a great rest of your month. This is Andy Brokenborough signing out until November. Have a great day.